Wading through tropical urban floodwaters contaminated by rat urine exposes patients to the corkscrew-shaped motile spirochete Leptospira interrogans, which penetrates mucous membranes or damaged skin to incite a widespread systemic capillary vasculitis. This initial Anicteric bacteremic phase presents as an acute febrile illness marked by severe myalgias localized intensely to the calves and lumbar region, paired with pathognomonic non-purulent conjunctival suffusion that characteristically spares the corneal limbus. National clinical practice guidelines mandate immediate risk stratification based on exposure history and clinical presentation because standard serologic assays like enzyme-linked immunosorbent assay lack diagnostic sensitivity during the first week of symptoms, whereas the gold standard Microscopic Agglutination Test requires acute and convalescent titers, yielding retrospective utility. Local therapeutic algorithms dictate prompt, targeted antimicrobial selection to abort tissue dissemination and prevent progression to severe systemic involvement. Outpatients presenting with mild, uncomplicated infection are prescribed oral Doxycycline for 7 days, which shortens the duration of fever and urinary shedding. For pregnant women or children under the age of 8, where tetracyclines are strictly contraindicated due to risks of fetal bone growth restriction or permanent dental enamel discoloration, oral Amoxicillin or Azithromycin serves as the primary alternative. For individuals with single high-risk wading exposures, post-exposure prophylaxis using a single oral dose of doxycycline within 72 hours reduces clinical disease incidence, while continuous occupational or environmental exposure warrants weekly chemical prophylaxis. A subset of patients progresses rapidly into the severe icteric form, known as Weil's syndrome, which is defined by a classic triad of profound conjugate hyperbilirubinemia driving intense jaundice, non-oliguric or oliguric acute kidney injury from acute tubular necrosis, and a hemorrhagic diathesis characterized by epistaxis, petechiae, and purpura. Severe cases require urgent inpatient admission for intravenous penicillin G or third-generation cephalosporin therapy like ceftriaxone. This hemorrhagic pneumonitis carries a high mortality rate, requiring immediate lung protective mechanical ventilation alongside aggressive renal replacement therapy via hemodialysis for refractory uremia or fluid overload. Close monitoring of electrolytes is vital since profound hypokalemia and wasting often precede the oliguric phase of renal failure.